if we think about lymphoma is a disease that lives in the microenvironment. We have a lot of tumor B cells, there are macrophages, there are dendritic cells, there are regulatory cells, and how can we attack a tumor that lives in this sort of environment? So one way we can do it is a way that we've gotten very comfortable with, and that is use antibodies to cell surface molecules. Of course, the most successful single immunotherapy ever in the history of mankind, I will stand by this, is rituximab. It has fundamentally changed the outcome of patients. There are way more patients alive today because of the ability to target CD20 in B-cell malignancies. There are new novel ways of targeting the B cells, and we'll approach some of those. We also have small molecule target pathway inhibitors, whether they be pathway inhibitors or BH3 mimetics that interfere with apoptosis. We also know that the microenvironment is rich in regulatory cells. If we look, take follicular lymphoma as an example, there are frequently more T cells present in the follicular lymphoma than there are malignant B cells, and this provides an opportunity to try to reactivate cytotoxic T cells by interfering with inhibitory signals via checkpoint inhibition, or directly take over T cells and make them drugs themselves. So there are a whole bevy of different approaches that are being undertaken. We have cell lineage targeting with either new unmodified monoclonal antibodies, CAR T cells, bispecific antibodies, and antibody drug conjugates. There's immunomodulation, whether it's via checkpoint inhibition or actually encouraging new neoantigen presentation. This is a just emerging area in the lymphoid malignancies. We have pathway inhibition, whether it be the BTK, SYK, PI3 kinase, AKT, mTOR, apoptosis, and the list is actually substantially longer than that. We'll talk a little bit about IMiDs and CELMoDs. The major one in lymphoma right now is lenalidomide, though CC122 is an emerging molecule. And then we have the epigenetic modifiers, including histone deacetylase inhibitors, hypomethylating agents, and taseminostat. This is a big list of lots of drugs. I think I've convinced you that there's a lot to talk about, but we only have 20 minutes, so we're going to focus on first-line large cell lymphoma and follicular lymphoma. We can talk about other opportunities, diseases, and pathways when we have questions and answers. So what about large cell lymphoma? This is the international standard of care, rituximab and CHOP, established by the then Gila group, now the LISA. The addition of rituximab to a CHOP chemotherapy improved event-free, progression-free, disease-free, and most importantly, overall survival. These numbers actually have improved over time, as you're going to see in a moment, so that our ability to cure patients with rituximab and CHOP, it's probably on the order of 65 or 70% of patients are now cured with rituximab and CHOP. Why is it a little bit better than here? Well, first of all, remember, these were patients who were 60 to 80 when they were treated, and we treat patients of all ages. But also, we've gotten much better at supportive care. But I always like to look at the tail of this curve. This means we should put rituximab in the water because the curves continue to separate even, 10 and 15 years after treatment. I'm just kidding about that, but the fact is that this is a sustained benefit over time. So our colleagues at the National Cancer Institute developed the dose-adjusted EPOCH regimen, a phase 2 study performed in the CLGB, now the Alliance, suggested that there was tremendous activity, particularly in germinal center B-cell lymphomas for the dose-adjusted EPOCH regimen. And this led us to conduct a prospective trial of dose-adjusted EPOCH versus R-CHOP21. Actually, the primary endpoint was molecular analysis of these tumors. That is still pending, but we have the clinical outcome. And unfortunately, this was the outcome. Dose-adjusted EPOCH was not significantly different either in progression-free or overall survival. So just rearranging the deck chairs and giving drugs in a slightly different way was not enough to change the outcome. But one of the things I want to point out is I would actually argue that the dose-adjusted EPOCH worked exactly what the statistical plan predicted. But what happened was the R-CHOP did way better than the statistical plan predicted. We actually had planned in the statistical plan for this PFS curve to be down here for CHOP. Because remember, I just showed you the original research curve. This is way better, okay? So the dose-adjusted EPOCH did what we wanted it to do, but R-CHOP did better than we expected. And that is a recurrent theme we have seen in the development of treatments for large cell lymphoma. I don't actually have time to address it, but it has a lot to do with if you wait too long to treat patients, all of the really sick patients are taken out and the outcome improves. The really sick patients, the patients who need treatment within the first 2 weeks, have a long-term inferior outcome, and they're underrepresented on all of our randomized clinical trials. But it seems that R-CHOP is a reasonable platform, okay? Now, you got to see, there's not enormous room for improvement, but there is still room for improvement. And there are different strategies to improve upon R-CHOP. You can use unselected patient populations. So you just take all patients with large cell lymphoma, you get R-CHOP plus X versus R-CHOP. So you need, if you're going to use a completely unselected, how about a broadly acting agent that works across different subtypes of large cell lymphoma, like polatuzumab? Or you might have a targeted therapeutic, but you're not entirely sure that you know what the biological subgroup is. So you might want to reanalyze the subgroup in a randomized trial. An example of that is lenalidomide. It's actually, I can put it in this category and in this category, and I'm going to show you both trials. And then there might be drugs where there is probably a biomarker selection, but we simply do not know what it is. And so you do an unselected trial and you do a post hoc analysis to find out what the biomarker is. There are reasons to do selected studies with R-CHOP plus X when you know what the mechanism of action of the drug is and where it's expected to work. So for instance, you're not going to use brentuximab vedotin in diffuse large B-cell lymphoma that doesn't express CD30, okay? It's unlikely to have a lot of activity, though there is some activity, which is a little weird. But that being said, it makes sense to have the biomarker that you're targeting. But we also have situations where the preliminary data says, oh, we know that, for instance, ibrutinib is more active in activated B-cell large cell lymphoma, or lenalidomide is more active in activated B-cell lymphoma, and we want to pre-select those patients. So how can we do such a thing? So one of the, I just mentioned ibrutinib. We're going to hear a lot more about ibrutinib during the course of the day, but one thing I want everyone to walk away from here today, because I might be the only person who says this is not a B-cell receptor drug. Okay, this does not target the B-cell receptor. It targets BTK, and BTK is downstream of CXCR4, CXCR5. Actually, probably this is the key for CLL, not this. It is downstream of the BCR. It's also downstream of the toll-like receptor. And it's important for signaling through the toll-like receptor and IRAK4 and the BCL10 MALT complex and activation of NF-kappa B. So this is a pathway inhibitor that has multiple effects, and it will depend on the nature of the biology of the tumor, which of these pathways is the critical pathway. In lymphoma, in diffuse large B-cell lymphoma, we think that actually this interruption of the NF-kappa B pathway is key. Why do we think that? Well, that in part comes from our studies of activated B-cell lymphoma, which is an NF-kappa B dependent pathway, and that's where we see the activity of ibrutinib. This was a phase 2 study in relapsed refractory patients, and the blue bars, the dark blue bars, are the patients with activated B-cell lymphoma, and you can see that most of the responses were among the ABC tumors. There are only a couple of germinal center B-cell tumors that responded. In fact, this is one of my patients right there. He was the outlier. He was the only person who responded with GCB disease. So this led to a pre-selected patient population trial for diffuse large B-cell lymphoma. They had to be non-GCB. The selection in this study was the Hans algorithm using immunohistochemistry, though then retested with nanostring, a gene expression profiling way of determining ABC versus non-ABC. And this was a randomized trial. It's done, and the DMC has met and actually has released data to someone, but not to us. So we will find out, hopefully at ASH, what the answer is, but this is one of the important trials. Lenalidomide is a pleiotropic inhibitor. We know the molecular mechanism of its action, that lenalidomide binds to cereblon and alters the degradation of critical proteins, but it still has a pleiotropic effect. It affects T-cell synapses, it affects ADCC and NK activity, and it has important effects on the tumor microenvironment, and in some tumors has direct effects on the tumor itself. If we look at the role of lenalidomide in large cell lymphoma, when we gave lenalidomide to patients with diffuse large B-cell lymphoma, we found that patients had very, very modest activity. However, when we look by cell of origin, about half of the patients with non-GCB tumors had activity, and that had some durability, not great in the relapse refractory setting. This led to some trials of lenalidomide combined with rituximab and CHOP, and interestingly, based on the preclinical data, we saw that the non-GCB patients clearly had an improvement compared to a historical control. This is not a randomized trial, this is historical control, but the GCB patients did not benefit whatsoever. So this led to 2 clinical trials. One, let's prove the hypothesis in a randomized way. So this is the ECOG trial that compared RL-CHOP to CHOP, and then the question was, is the cell of origin really predictive? And then we have the robust trial, which we know the answer, so let's just cut to the chase and do the trial. This trial is also in the can, and we will see results at ASH. So what about drugs that work more broadly across tumor types? And so we have antibody-drug conjugates, where now using the antibody not necessarily to kill the tumor cell, but to deliver drugs to the tumor cell that can kill it. Now, here are some of the drug conjugates that are in clinical development. And basically, these are a list of drugs that have, in general, a negative therapeutic index, meaning that if you try to give these drugs as a systemic drug, there will be far excessive toxicity to benefit. But these are really good drugs for killing tumor cells. So how do we get drugs with a negative therapeutic index to have a positive therapeutic index? You give tiny amounts of drug directly to the tumor. And all of these drugs actually have a negative therapeutic index, but we can change that by creating antibody-drug conjugates. So polatuzumab vedotin is a late generation, a late ADC that is now in randomized phase 3 trial. So I'm going to sort of focus on that. Actually, Nancy's done a lot of this work. So the original work with polatuzumab was a dose-finding study where the MTD was determined to be 2.4 milligrams per kilogram. There was a good overall response rate. However, there was really excessive neurotoxicity. When the drug was reduced to 1.8 milligram per kilogram, added to rituximab, there was also a reasonable overall response rate in the relapse refractory setting, and then a randomized phase 2 study compared bendamustine rituximab to bendamustine rituximab plus polatuzumab at the 1.8 dose, demonstrating a doubling in the response rate as well as a doubling in the progression-free survival. This was the rationale for this is the phase 1b combination of POLA with R-CHOP. The response rates compared to historical control from Goya, which was the negative trial of obinutuzumab CHOP versus R-CHOP. This uses the R-CHOP control and demonstrates that the overall response rate is higher, the complete response rate was higher. And if you look at the PR CHIP patients, the progression-free survival is looking relatively favorable, though if you remember, that looks a whole lot like 50303, so be warned. So this is the ongoing trial, and it's available nationally, and it's available in your practices, and that is a placebo plus R-CHOP, R-CHIP, versus polatuzumab plus R-CHOP versus polatuzumab plus R-CHIP. So there are actually two placebos involved in this study. You get a placebo vincristine in this arm, and you get a placebo polatuzumab in this arm. Patients get 8 cycles of treatment, and that's to make the Europeans happy. So that's why there's these 2 extra doses of rituximab, not standard in the US, but it is standard in Europe. In the last couple of minutes, I'm going to talk about follicular lymphoma. These are our options, right? So if you have patients who need treatment, not observable patients, but patients who need treatment, we have multiple options for adding rituximab to a chemotherapy backbone, or in certain cases, in selected cases, rituximab by itself. One of the emerging options is rituximab with lenalidomide. I'm going to talk more about that. If we look at the meta-analysis of rituximab plus CHOP, what we've determined is that there is an overall survival advantage in favor of adding rituximab to a chemotherapy backbone, and it is therefore the standard of care. So first-line follicular lymphoma, the standard of care is rituximab plus chemo because it results in an overall survival advantage. What we don't know is what's the optimal R-chemo regimen to use, and there's been a lot of debate about that. So I'm going to talk about 2 of the more recent trials. This is the Gallium trial, which asks, can we improve the antibody in the trial? Obinutuzumab is a type 2 monoclonal antibody. It is glycoengineered so that it has enhanced ADCC. It has substantially reduced complement-mediated fixation. And the reason is that that these type 2 antibodies don't cause CD20 to aggregate into lipid rafts. And so it works quite differently. But interestingly, all of the therapeutic antibodies bind to the same 44 amino acid, little tiny domain, and they all cross-block each other. So you can't give two anti-CD20 antibodies at a time because they just cross-block. So the gallium study was you had to pre-declare which chemotherapy you were going to use. It was going to be CHOP-based, BR-based, or CVP-based. And it was not based on the patient, but on the center. Okay, so if Memorial, we actually chose that all our patients were going to be CHOP-based, so everyone got CHOP. So patients were randomized between G-CHOP versus R-CHOP, G chemo versus R chemo, and then they got either obinutuzumab or rituximab maintenance, and there was a variety of different analyses. Here's the overall response rate, no difference. Okay, so changing the antibody didn't change the overall response rate. It didn't really even change the complete response rate. So it looked like a negative trial. However, if you look at the primary endpoint, which is actually investigator-determined PFS, and it was actually confirmed by the IRC PFS, both statistically in favor of the obinutuzumab. Time to next treatment was in favor of obinutuzumab. No difference in overall survival to date, but this is an extremely short follow-up. So what about other analyses? One of the important endpoints of this study was to look at minimal residual disease. And minimal residual disease was monitored during the maintenance and then after the completion of therapy. And the question was, is there detectable or undetectable minimal residual disease? There's no such thing as MRD negative. It's MRD undetectable. We can talk about the difference. So interestingly, the obinutuzumab was actually had better rates of MRD undetectable disease compared to rituximab. And if you were MRD undetectable, you actually had a better outcome than if you were detectable. And in fact, we can make this even better by combining the PET result with the MRD result. And if you're MRD negative, PET negative, you actually do extremely well. But if you're either PET positive or MRD positive, you have a more inferior outcome. Obviously, if you're MRD positive and PET positive, you do quite poorly. But it's a tiny number of patients that fall into that category. So should we worry about bendamustine in first line? This is something that came out of the gallium study. The answer, in my opinion, is yes. This is maybe the most important thing for your practice, is there was a significant non-cancer related death rate associated with bendamustine in the gallium study. It was 5% compared to 1.8% for CHOP and 1.7% for CVP. No, that's not 1.7%. I'm sorry, that's 0.7%. That's a typo on the slide. I apologize. And the BRIGHT study, which was the confirmatory study of the STILL study, showed that there was a 9.4%. This is a U.S. study. 100% of the patients were treated in the U.S. You can't say, oh, people didn't know how to use bendamustine. 9.4% risk of death, non-cancer related in BRIGHT versus 4% with either CHOP or CVP. The STILL never reported this information, so we don't know. But I actually think that there is a risk of non-cancer related death from bendamustine, and it has to do with immunosuppression. And I actually do not use bendamustine in upfront patients unless there are extenuating circumstances. And then just one quick comment on the Relevance trial. Relevance was a study looking at whether rituximab lenalidomide is an appropriate treatment compared to a standard R chemo, and patients were randomized, and then they either got rituximab maintenance or lenalidomide rituximab maintenance for a year, followed by rituximab maintenance for a year. Here are the patients, well-balanced study. This was the primary endpoint, and there is no statistical difference between rituximab lenalidomide and rituximab chemo. And if we look at the progression-free survival, and this is an interim analysis, no difference in progression-free survival. So this was a negative study, and the major unique toxicity is cutaneous toxicity, and there's a lot of rash associated with the lenalidomide rituximab combination. No increased risk of second primary malignancies. This is really an important analysis because lenalidomide has been associated with second primary malignancies. This is a prospective trial showing absolutely no difference in second primary malignancies. So relevance is a negative trial that I actually think provides us with a new option for treatment, because the trial was designed to show that rituximab lenalidomide was superior. It is not, but it is an option for treatment. So with that, we're going to take questions at the end, and if there are favorite drugs I haven't touched on, maybe CAR T cells or something like that, we can discuss it at the panel discussion. It's my pleasure to have Nancy Bartlett come up, and here are Nancy Bartlett's lovely children, and got snuck in there. Nancy is an old friend and colleague, and has been a leader in the development of new therapies in non-Hodgkin lymphoma, and is going to talk to us about how